on the Zoom. All right, guys. I'm going to get my lab manual out, and then we're going to get rolling. Okay, blood vessels, right? So let's start on page 2. So the top left arrow is what we call a neutrophil, right? Does everybody know what a neutrophil is? A neutrophil is a white blood cell that will respond to bacteria, a bacterial infection. It's a segmented cell. Well, sometimes if they're immature, they'll become bands, but as they mature, they become segmented, and they basically respond to bacterial infection. And they release hydrogen peroxide. That's how they kill bacteria. Another cell type that a neutrophil is, it's also called a phagocyte. Does anybody know what a phagocyte is? A phagocyte is a cell that consumes its bacteria. It's kind of like a monocyte. We'll talk about monocytes. That's the last one. All right, the second one, the one in the middle, top right, that kind of looks like pink and purple, is called an eosinophil. Eosinophils are kind of interesting because they'll respond to parasitic infections as well as an allergic reaction. So if you're allergic to peanut butter and all of a sudden you taste something that has peanut butter in it, you're going to get a burst of EOs. We call them EOs in the lab world. My specialty is hematology oncology, so this is like right in my realm. We'll have a huge EO release from the bone marrow. And the interesting thing is that these EOs have granules in them. And they have the granules, instead of filling with hydrogen peroxide, they're filled with histamine. Histamine does all kinds of stuff that we won't touch on. That's why if you've got allergies or you're sneezing a bunch, you would take antihistamine to block the EOs. EOs are the ones that makes your nose runny, makes your eyes water. You know, you'll probably see me doing a lot of that here in a couple weeks, maybe 6-8 weeks, probably 2 months actually. The one on the far right is called a basophil. Okay, there isn't really a particular job that a basophil does. I doubt it'll ever show up on a quiz or an exam. Now that I say that, the picture may, but the functions won't, because you can't really tie down what the hell a basophil really does. It's involved in cancer. It could be involved in cancer response, or it can be involved in virus infection, excuse me. But that's not the primary, and that's all we're going to say about basophil. I don't want to touch on it too much. What really is the viral response, and this is what I see in my line of work, is when these people come in with possible COVID-19 infections, is that they will draw their blood and we will run what's called a complete blood cell count. They look at their white blood cells. So if I were to make a slide and then look underneath the microscope and I see a predominantly lymphocyte line lineage of cells, that means that they have some kind of viral infection. So lymphocytes are the bottom left, and that is your viral response cell, also known as a B cell. It's the cell that makes antibodies. So when you take a vaccine, this is what your vaccine is stimulating. Your vaccine is stimulating lymphocytes to produce antibodies, or i.e. Immunity, to help combat a typical certain viral response. Now, when these things get activated, they get big and bad looking. They get real dark. They stain really dark, and their cytoplasm almost looks like a tongue. It's kind of interesting. You'll see like a normal one, like let's say this is your nucleus, and then this is your cytoplasm, which is something special. When these things activate, when they're actually actively producing antibody, they will actually look like a tongue, like that. And let me let you guys see this, and if you didn't see it, they will actually look like this. Like this would be the normal one, and then this would be your activated one. it's kind of interesting because that's when you know that you're really in a serious infection, similar to what happens when you have like a blood infection with neutrophils. When the body is like a very robust infection, the bone marrow will react by sending out all these immature cells because they're trying to get as many cells on the line as possible to combat this infection. You can pick that up on a microscope, and you can tell if the neutrophils be more or less, more immature. Then you would have more like a banded look, kind of like something similar to this. Here's your cell, and it'd be like a U-shaped. And then eventually, they'll be kind of like lobed, kind of like that. So somehow this will break in half, and then they'll lobe out, and that's what's called a mature neutrophil. I don't think we're going to be getting too much in depth with that, but it's just kind of interesting how white blood cells can change to meet the demand of a certain infection. Okay, and the last one on the right, the bottom right, that's a monocyte. Kind of looks like a U there. That is also what's called another phagocyte. And it will, the interesting thing about monocytes is that they migrate. So what do you mean migrate? Well, think about it. So if your bone marrow releases white cells and red cells, they'll release them into your peripheral blood system, okay, which is outside your bone marrow. If you were to, let's say you got a new pair of shoes and you got a blister all the time. Not that I have a new pair of shoes, but every time I seem to switch shoes, I'll get a blister on the back of my heel. Let's say all of a sudden now I've created this wound on the back of my heel, and sometimes feet can be a little dirty, may have a little bit of a staph infection. It happens. It's relatively common unless it's MRSA. Monocytes and neutrophils are able to migrate out of the vessels, out of the capillaries, and into the tissues. All right. And that's, if you think about it, if you have a superficial wound, that's where they need to go to combat the infection. So it'll leave the vessels or the capillaries and then go and try to consume the staph cocci, or it's going to be a cocci at that point, which is a type of bacteria. So I think that's all I want to talk about with white blood cells. Is there any questions for you guys? Good? Okay, rolling on. Any questions online here? Okay. Let me get this chat up just in case. All right, so we're good. I guess you guys can hear me pretty well if I'm moving around. Okay. All right, so there's one other cell we haven't talked about. An erythrocyte, and I don't have a picture of an erythrocyte. Normally what would happen, you can always Google erythrocyte. Does anybody know what erythrocyte is? Yeah, red blood cell, right? Yeah, good. All right, cool. So as you move on down your academic careers, you're going to hear these different cell types, and the fancy words are the scientific words, and then we also know about the common words. Like you'll hear me say RBC, red blood cell. Eosinophil, I'll call it an EO. Monocyte, mono. So it's important that you kind of catch on some of these different words so you don't get confused. I'll try to explain what I'm actually talking about. If I'm talking over your head, then we're wasting everybody's time. So if you pick up on a vocabulary word that you don't recognize, just say, what in the world are you talking about, please? Because I was in your all seats just probably a couple years ago, and I'm like, what are these people talking about? I don't know the lingo. So let me know. So an RBC, does anybody know what an interesting thing about an RBC is, a red blood cell? Anything? There's one thing that you will likely have a question on sometime in your academic career. And the cool thing about red blood cells is that they do not have a nucleus. All right. If you look at it, if you think about these other cells, nucleus, 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 nucleus. And there's a difference. They at one point in their lives, they do have a nucleus. And that's when they are in the bone marrow. Okay. When they are maturing in the bone marrow, they have a nucleus. We call that a nucleated red blood cell. when babies are born, when they have babies born, especially premature babies, or they have to take them early for preeclampsia reasons or high blood pressure, they're gonna send some blood down to the lab, and that's what I do on third shift. And then they're gonna have me look at it, and I can kind of tell how stressed the baby is, given the amount of nucleated reds that are found in the peripheral blood. Normally you will not find nucleated reds in the peripheral blood. They're always going to be in the bone marrow. So when you have nucleated reds, what's the one thing that red blood cells do? Sorry? They carry oxygen. If they have a nucleus, they can't carry oxygen. So they're just hanging out. They're useless. But the body does what it can. Does anybody know the last organ to develop in a fetus? You have liver, you have heart, you have kidney, you have lung. Does anybody know?
The heart.
The heart is actually, the heart may be the first, actually. We always hear that abortion claim that the heart starts beating at like 6 weeks. So that's the relatively early one. If you've ever noticed what the big deal is when you have premature babies born, they have a hard time breathing. Their lungs have just developed within days. Don't ask me the weeks. I think it's like a 40-week gestation. I don't know when the lungs develop, but they're the last ones to develop. And sometimes when these babies are taken early for whatever reason, they struggle very hard to breathe. They actually have to give them a solution called a surfactant. And we will touch on surfactant, but what it does is that the lungs are made up of these alveoli, right? And they have to be, it's like a balloon, and they have to be blown up to exchange oxygen. When these babies are born, the alveoli are not completely developed, and they're closed. They kind of like collapse on top of each other. When you were to give these babies surfactant, it helps expand them so they can use this mechanism to exchange oxygen. So it's cool. Let's say they are breathing. However, we don't have the red blood cells to carry the oxygen. So it's somewhat useless. You're in that case, what you're really doing is just inhaling air and then exhaling air, because we cannot diffuse the oxygen into the lungs. So what happens is, one thing that can happen is that eventually the spleen will clean these red blood cells, and they will pull the nucleus out. So then all of a sudden it's an active red blood cell, and then it can carry out its job. So the interesting thing is, I guess the point I'm trying to make here is this little anecdote, is that red blood cells, it's eventually at one point they're going to have a nucleus. They're probably one of the only cells, there may be one or two others that I cannot think of, that do not have a nucleus, okay? So if you ever see a question about what cell type does not have a nucleus, one of your chances of red blood cell, circle that thing and move on. Don't get stuck into some other, okay, so erythrocyte, red blood cell, reds, RBCs, all the same thing. All right, so we kind of rolled through that graph or that table fairly quickly. Is there any questions? All right, well, just, holler at me, because this is when we're gonna start blood bank and blood typing. And I had to shake the dust off on Tuesday on this stuff. Okay, so I'm on page 3. All right, I'm starting blood typing on page 3. Now, antigens and antibodies. Agglutininogens and agglutinins. I really want to focus on those first two words, antigens and antibodies. You probably won't ever hear me say anything about agglutininogen or agglutinin. If that does show up on the quiz or the exam, I will likely throw that question out. In the field, what do we want to do? Are we nursing? Are we hygiene? Are we radiology? Are we nursing? Okay, maybe a little undecided. Okay.
Nursing.
Nursing. Okay, cool. Well, nurses, y'all are going to be, chances are, at one point in your careers, your patients are going to need to be transfused, and this is kind of when we kind of get into blood banking and transfusion medicine. So this is going to be your first introduction. Hygiene, will probably likely never use this. Radiology, no, there's other things for radiology. And then surgical tech. Surgical tech they'll transfuse the hell out of somebody in surgery if something goes bad. There was a lady a couple months ago, they tried to take out a gallbladder, and something happened is that something ran a line and it poked a hole in her hepatic artery. And I've never seen so many people freak out and run into the blood bank. They probably transfused her with 15 units. She survived. She was probably about 34 years of age. It would have been a wrongful death. It would have been a complication that was a routine surgery. You've always heard that surgeries are never routine, and that's the truth. They're really not. She was just going in to get her gallbladder taken out, and she had a malformation in her hepatic artery, and freaked everybody out. You're always supposed, as a surgical tech, you're always supposed to remain calm when you have to go and get blood, because it's enough to get the blood out in an emergency transfusion. This lady, I think it was her first day. I don't know what happened. She was in there freaking out. You just got to keep calm and do your job and get the blood to the patient. All right, so enough of that. I got to get back. All right, so if you guys have questions online or in person, just holler at me before we get going, because eventually this stuff is going to stack. So blood type A. Let me do my introduction first. Okay. Well, we've talked about immunology with these guys. All right. The interesting thing with antigens are how we identify cells. Antigens are on everybody's cell type. Okay. It's kind of like how you recognize my face as Drew Mattmiller, right? Antigens are how we recognize these cell types, who they are, what they are, where they come from. Everybody has them. Antibodies, I've already used that word already. Antibodies are from the immune system, and they're produced by B cells, okay, which are lymphocytes, right? So, and they will either be hanging out on the cell surface, or they'll be free floating in circulation. Okay. When we transplant somebody with tissue, we have to line these up. Okay. Or the body will reject it. I'll get more into that later on, but this is kind of what we're going for here. The last two words, agglutinin, I pronounced it better earlier, and agglutinins, I'm not going to worry about those two. I don't think you will. You won't use those in the field. You will use antigens and antibodies. So blood type A. So we all have these red blood cells, right? And in order for us to transfuse somebody, we all have different blood types, and we have to match them up. We have to match up these antigens for reactions not to occur, and we don't want something to occur in the body. So what are these antigens? Antigens are what you have to write this down. This is just my spiel because I'm building it up. Are glycoproteins, right? And they're made up of genetics. Like, how do you get this? Well, you get one gene from your mother and you get one gene from your father. They come down and they make this antigen, all right? In the state of Kentucky, if you were born and raised here, chances are the population is going to be A positive, 40% A positive, okay? Which means, and we'll talk about the positive and negative next, but let's just focus on the letters. So we have A, B, O, and AB, all right? The A blood type is going to have the A antigen, all right? You want to write that down under that space. Antigen, blood type A is going to have the A antigen. B is going to have the B antigen, and then AB is going to have both, and that's probably about a 4 or 5% population percentage. B's, I think, is maybe around 15 to 10%, and then O is, I might shut that door. O is different because O does not have the antigen on there. O is nothing. O is 0. So when you think, we probably all heard O negative, right? O negative, or O, is a person that can give blood to anybody because they don't have an antigen at all. Zero. Think of that O as like zero. All right, had to shut that door. Okay, so let's go up to antibody. This is where I always got confused when I was learning this, because normally when you have to get an antibody, you have to like induce an antibody to be made. This is completely different. This is naturally occurring antibody. So if somebody has a blood type A, they have the A antigen, you're not going to want to make the A antibody, right? Because if you think about it, the purpose of antibody antigen is pretty much like a cat and mouse game, all right? It's like cops and robbers. And what happens is that the antibody's job, this is my antibody, is to go and find this antigen and bind to it and clump it up, make it bigger so the immune system can recognize it and we can discard it, right? We don't want that to happen in our blood, right? That, if that does happen, it's what we call an autoimmune disease, all right? Lupus, they think multiple sclerosis is, they think myasthenia gravis, I think, is another one. It's a neurological disease. They think it's some kind of autoimmune disease gone bad. They also think type 1 diabetes is a autoimmune disease that takes out your beta cells in your pancreas. Anyways, so we don't want antigen, we don't want the A antigen and the A antibody to be anywhere near each other, okay? Keep that in mind. So when I say A antibody, or the A blood type makes the A antigen, it does not make A antibody, it makes B antibody. So blood type A under antibody makes B antibody. And if you think about it, it's just the opposite for B blood type. And that is A antibody. You guys okay online? Just chat something or speak up and holler at me.
Yeah, we're okay.
Okay, thank you. All right, and then blood type AB is, like I said, you get A antigen and B antigen, and then that is no antibody on blood type AB. Okay, so for blood type O, we don't have any antigen at all, right? So blood type O people will have naturally occurring antibody A and antibody B. All right, so now we're getting in this Rh positive and Rh negative. That is the positive and negative part of blood types. Now, why do we care, right? The interesting thing about blood cells is that they have probably hundreds, if not thousands, of different antigens on their surface, but we only care about 2 of them. There's more, but for this class, we only care about 2 of them. Because if you were to put these red blood cells in somebody else's body, these kind of antigens can start up the immune system, all right? They're so potent that the immune system can recognize it and kill it. Has anybody heard of HFDM, you probably haven't, hemolytic disease of the newborn, fetal disease of the newborn, HFDN. Huh? Yeah, you're close. Yeah, so basically what happens is that this is what happens when baby's blood is a different blood type than mother's blood, okay? And what happens is that baby's blood will sometimes leak into mom's circulation, stimulates mom's immune system. Mom's immune system will make antibodies toward baby, which could, well, it does kill baby over time. Now, it's not a big deal in the first child because at that point, it's probably, we've probably already given birth to the first child. But we have all these antibodies hanging out that have been made from first baby. If mom gets pregnant with second baby, and we have the same situation where I can't remember the circumstance, but it's obviously it's different blood types. And what happens is that now second baby's blood may leak into mom's circulation. All of a sudden, these antibodies will cross the placenta. If we remember from Bio137, we talked about IgG, IgM, IgA. These are different antibody types. There's only one type that can cross the placenta, and that's IgG. And what it does is it come in and it'll just wipe out baby number two, probably within 4 or 5 days, 3 or 4 days. Sometimes this happens, and when it happens, it's when people haven't had prenatal care, and they've had babies before, and the baby will either come in stressed, or unfortunately, in some cases, it's a poor outcome and it's a stillborn birth. It could all be avoided by a pharmaceutical agent that we call Rogam. All right, and we will give these mothers Rogam throughout their second baby's pregnancy to neutralize these antibodies that have been made against this baby. The interesting thing is, it's a very simple concept, or it's a very simple, well, it's a concept, mechanism. You're just neutralizing these antibodies, but nobody really knows how it works. We just give them doses. Like sometimes these pregnant women will come in and they will fall, and then, obviously if they have some kind of trauma to the fetus, then chances are this blood could leak into their circulation, and then it gets sent to me. And then when they draw on mom's peripheral blood, there is a reaction that I can do to show how many baby cells are circulated in mommy's blood. I will report that out, and then the nurse and the physician will give the appropriate amount of Rogam doses so we do not wake up the immune system and it'll attack the baby. So it's kind of important. It's a big deal. So back to this antigen stuff that I want to talk about. The second antigen type that really can elect the immune response, when I mean elect, I mean stimulate it and get it going, is the Rh antigen system. And it's kind of interesting. Well, why is it Rh? We have A, B. Why are we naming it something else? When they were working all this out in the 50s, they used rhesus monkeys, RHESUS. So they just named it Rh. So if you had the antigen, the Rh antigen, then you were positive. So Rh positive, that antigen means you have the Rh antigen on your red blood cells, and we have to accommodate for that. Rh negative means you don't have the antigen. Okay, so and it's opposite for the antibodies. If you have the Rh antigen, you do not have the Rh antibody. So one last concept, and then we'll kind of move on to this case study that may take some time to roll through. The Rh antigen is something that we have to keep tabs on, and that is the Rh antigen basically is the one that we have to watch when we give blood to pregnant women. If they are Rh negative, we do not want to give them blood that's Rh positive, because now you've just given them this new antigen, and what happens is that the body will produce antibodies against that. So what happens is that if a female of childbearing age were to receive blood or need blood, we will give them Rh negative blood, because the Rh antigen is the one that really we have to worry about when it comes to babies. All right. So we always try to focus on getting them Rh negative blood. I think that's all I'm going to say about that. I don't want to go any more in depth. All right. Let me pull this down. I guess you guys have been talking amongst yourselves over here. Okay, no questions for me. All right, cool. All right, so any questions on that? Because then we're going to do a case study, and it'll make more sense when we do the case study. Because when we do the case study, we're gonna get into what I do if I were to transfuse somebody. All right, so on part C, so white blood cell count, the normal white blood cell count is from 5 to 10,000, all right? That is millimeters per mercury. I think MM3. I had to Google it. I could not think of that. Is that right? Okay, I had to think about that on Tuesday because usually it's millimeter per deciliter. I don't want you to get caught up on the units, but I do want to draw your attention to, we have 5 to 10,000 white blood cells, and then from the red blood cell count, it's in the millions, okay? So that's a couple orders of magnitude, right? We have 4.6, 6.2 million, and then we only have maybe about 5 to 10,000 in our white blood cells. So just pay attention to that. I'm not sure if there's questions. I think when you get into the elevated or even on your nursing license questions, license exam questions, just be aware of what units they're talking about. You know, they may say 5 to 10,000, but they may be in the millions, and then you just answered it wrong. So just make sure you understand that the units, you know, it's going to be 5 to 10,000 millimeters per mercury, and not 5 to 10 million whites. It's 4.6 to 6.2 red blood cells. Okay, let's talk about terminology. Define terms. Leukocytosis. Does anybody know what leukocytosis is? We can break this down. I'm going to kind of do some medical terminology here. Leukocytosis. So, osis means there's an abnormality, right? It's something's going on, and that is like that is going to be applied to any medical condition is osis, right? Unless it deals with blood. Blood's different. Blood's emia. Osis is something non-blood. Cyto means cell. Leuko means white. So put this all together and we have white blood cell, an abnormality of the white blood cell. And what this really is a severe increase in white blood cells. You will see this in infection. You will see this in hematology oncology. What I mean by hematology oncology is cancer of the blood, leukemia, lymphoma, multiple myeloma are the 3 big ones. Okay. And just to give you an idea, last week there was a 79-year-old that came in from the ER that he was off his cancer treatment. He had ALL, which is acute lymphocytic leukemia. No, excuse me, lymphoma. And his white blood cell count was 430,000. So normal's from 5 to 10,000. He was in the 400s. That's about as high as our analyzers will run them. If it was any higher than that, and I've had a little bit higher than that, but that's on like the 90th percentile. That's about as high as it can go. If we were to go any higher than 490, I would have to dilute the specimen so the analyzer can give me a accurate level of his whites. So that just kind of tells you how powerful cancer can be when you're talking about lymphoma and leukemia, especially leukemia. And he was an acute stage. So when you have an acute stage, that means it's just flared up. It's not a chronic situation. Chronic situation is more manageable. Acute is a lot harder. Okay, leukopenia. So penia means lessened or weakened, or I'm going to say attenuated, which is a synonym for both those words. It's a lessened response. So if leuko, like I said, is whites. So in this case, it's a low white blood cell count. The next one is I always struggle with this. Polycythemia. Polycythemia, which emia, if you remember what I said, emia is kind of dealing with the blood system. Okay, cyto is, or cyte in this case, is cell. Poly is many. So that is a high red blood cell count. All right, and then anemia, which we may have an idea of what that is. I don't know what the and part is. I just know anemia is the blood, dealing with the blood circulation system. And then that would be a loss of red blood cells. like a hemorrhagic loss, trauma, and that's in that case, that's when you would need blood. All right. So online, folks, we okay? I mean, I'm sure that wasn't the most complicated material. I think everybody in person here is okay. Okay. All right. We're doing okay on time. Okay. So because we got in person and online, I want to go over this. And then for some of you in-person people, if we want to do this hands-on, we'll do it after. Okay. Thank you, Skylar. I got that. So we'll come back to the procedure, but let's go down to the graph, the table on page 4. Okay. Now, we remember my little, my monologue about antigens and antibodies and how we don't want them to bind in our body, right? If we do, that's some kind of pathological state, lupus, multiple sclerosis, et cetera, et cetera. Now, this is when we're coming into the blood bank and we have to figure out what this patient is, what their blood type is, right? We don't know. One way we figure this out is that we will put these antigens and antibodies together and see if they bind. And if they bind, then they clump up, which tells us what antigens they have. On your desk, and we don't have to do this right now, this is the factory-made antigens and antibodies, okay? This is what we use in the real world that helps determine when somebody needs blood and it's not an emergent situation, what their blood type really is. We can't just issue a bunch of O negatives, okay? The population can't hold it. We have to transfuse the correct blood type to get these people, back up. And it could be for all kinds of different reasons. So let's talk about Mr. Smith. Mr. Smith, we're going to designate Mr. Smith as A positive, all right? So below Mr. Smith's name, put A positive. All right, so for the first 3 columns, anti-A, anti-B, and anti-RH, those are our factory made, I'm going to call those reagents. That's what we use. Reagents is something that is factory made. This is what we use to problem solve on what these patients have. So anti-A is also known as antibody A. And then anti-B is antibody B. And then anti-RH is, you could guess it, antibody RH. So we said Mr. Smith is A positive, okay? So what does that mean? All right, well, we know that Mr. Smith has the A antigen, right? He's not gonna have the B antigen. And we said he's positive, so he's gonna have the RH antigen. If we put Mr. Smith's blood in a tube and we take the anti-A, the antibody A reagent and squirt a drop in there, then we've just put A antibody and A antigen in the same test tube. And we're gonna spin it down in a centrifuge, and then we're gonna look at it and wiggle it, and then we're gonna see this clump. We're gonna see this clump because the red blood cells of Mr. Smith have the A antigen, and we just put the A antibody from our reagent, from our factory-made tube together, and it's going to clump. That tells us that Mr. Smith has the A antigen, okay? Now, we already knew that, but in the real world, we wouldn't know what the hell Mr. Smith was until we put this A antibody in with his blood. And if we see clumping, that means that, okay, now we know he has the A antigen. Does that make sense? This is going to be the concept moving on. Now, remember, this is in the lab. We're not talking about in the body. In the body, we don't want clumping at all. That's a problem. All right, we okay on that? Okay. All right. So now, for antibody A serum in that box, we can put positive. Or we grade these clumps by 1 plus 2 plus 3 plus 4 plus. You can just put, you can say clumping or a 4 plus in that case. You can put 4 plus. I'm sorry. Does that sound? Let's put positive. Let's put positive. Let's not get into much detail. Yeah, in the anti-A serum, we would put positive because we know that now the antibody A serum or reagent, I should probably say serum, the antibody A serum, the factory-made serum, binds to Mr. Smith's blood because he has the A antigen. All right. So now we take that test tube, we throw it away. For the next test tube for anti-B, we squirt the anti-B reagent serum in a new test tube of Mr. Smith's blood. We know, because I gave you the information before, that Mr. Smith's blood is A positive. So he's not going to have the B antigen. He's going to have the A antigen. We'll centrifuge this down, and we don't see any clumping. We see just we see what would look like red blood cells mixed in with water. It's just kind of like swishing around in there. There's no clumps. That's a negative result. So we know that because we used the antibody B serum from the factory and we mixed it in with Mr. Smith's blood, that he does not have the B antigen. All right? We cool? All right, we're cool. Maybe I'm making this too dramatic. Probably just because I hated this when I did it in your all seats. Hated it. Now, we said that Mr. Smith was positive, right? So we know at that case he has the RH antigen. So guess what? If we put the antibody RH reagent serum in with his blood, what's going to happen? Yeah, that's right. We're going to see some clumps because we said he's positive, right? So if he's positive, then that means that we're talking about the RH antigen. That means that those red blood cells also have RH antigen on them. All right, so what's his blood type? Well, I already told you that. It's A positive. Normally, we would do this on our own and kind of figure it out, but it's the same concept through and through. Antigens present. What do we know? A, right, thank you, cool. Antibodies present. Yeah, B, very good. All right, so I want to move on to Mrs. Jones. I think we're okay here online. We're okay in person. Mrs. Jones. We're going to say Mrs. Jones is B negative. All right, she's a little bit rare. She's probably in the 5 to 10% of the population that has B negative, at least around this region. So B negative, we take antibody A serum, we mix it with Mrs. Jones' blood. We don't see anything, right? Because she has the B antigen, because she's B negative. So we have no reaction on the anti-A serum for Miss Jones. For the antibody B serum for Miss Jones, we get a reaction, we get clumping with her blood mixed in with the antibody B serum because she is B negative. So we okay there? Okay, all right. Antibody RH, yes, none, that's right, because we said she's negative. So her blood type would be B negative. That's fine. You can say B minus. That's fine. It's the same answer. Antigens present. B. What's the antibodies? A. Okay, cool. Let's talk about Mr. Green. Now, Mr. Green's not going to be, Mr. Green's going to be, I always called Mr. Green it's easy to remember that, as a student said on Tuesday, green means go. I said, well, green means money. And what I mean by money is that when Mr. Green is going to be O negative. Mr. Green is highly coveted by KBC, Kentucky Blood Center, because they call Mr. Green all the damn time to come deliver blood because we need his blood because he is O negative. So Mr. Green can get a bag of money for his, they don't sell blood. You can get it for plasma. I'm going to call this. They say, oh, Mr. Green, we're so short on your blood that you have such a high demand that we'll stroke you a check so you can come in and give us blood. This is how I try to deliver this so folks can remember. Mr. Green, like I said, is O negative. All right. If you remember what I said about O negative blood is that they don't have any antigens on their cells. All right. I say, well, even though, hold on, Mattmiller, you said that he doesn't have any antigens on his blood, but you did say he's got O negative people have antibody A and antibody B. So if O negative people have antibody A and antibody B, and I need blood and I'm A positive, then I have the A antigen. How the hell can you give Mr. Green's O negative blood to me? Because remember, I'm A positive. I have the A antigen. Mr. Green, although he is O negative, he has antibody A and antibody B. So that antibody A will cross-react with my antigen A, clump, tell my immune system to kill all of Mr. Green's red blood cells and puts me in a pretty precarious position, dangerous position. Now, when they collect blood at Kentucky Blood Center, believe it or not, they'll make 5 products out of your blood. They separate it. They put it in the back and they tell all these lab rats to start cycling all this blood. And what happens is that when you are transfused in an emergent situation with Mr. Green's blood, you are not getting the whole blood. You are getting what's called packed reds, packed red blood cells only. All right. Remember how I told you antibodies are circulating around in the circulation? Those antibodies will be filtered out, 99.5% or 99%. Maybe, I don't know, maybe it's all of it. And then when you transfuse somebody, you are giving them packed reds. Now they'll mix it in with saline to loosen them up and to get them into your, and get the flow going into your body. But you do not get the whole blood. Because if you were to get the whole blood, then you get antibodies, you get fibrinogen, you get all the coagulation factors, plasma, all that. Is this one of my people? Okay, never mind. I'm sorry. Sometimes students text me and they want to let me know something. Okay, turn that down. Sorry if that blew everybody's ears out. Mr. Green, in this case, because he is such a highly coveted blood type, because he's O negative. O negative, I think, makes up, I want to say, don't quote me on this, but it may be 30 to 40%. I cannot remember. Maybe it's closer to 20. It doesn't matter. Anyways, so let's work up Mr. Green. We said Mr. Green is O negative, right? He gets, his blood goes to everybody. So we have no antigens on Mr. Green. So if we use antibody A serum and antibody B serum, we're not going to get any reactions, right? Okay. And for antibody RH, excuse me, that's also going to be a no reaction. So in that case, we know his blood type is O negative. So antigen present, he has no antigens. Antibodies present. That's right, anti-A and anti-B. That's in whole blood circumstances. If he were to give blood, we'd take the platelets out of him. We would take the fibrinogen. We would take all the coagulation factors out, and we would separate his blood into 5 different products. Miss Brown. Miss Brown is AB positive. So we may be kind of catching on here, but I still kind of want to hold everybody's hand. If we have antibody A serum and we mix it with Mrs. Brown's blood, we're going to have a positive reaction. Because it's the A antigen going with the A antibody. Miss Brown, antibody B serum is also going to have a positive reaction. And we said she's AB positive, right? So she's going to light up across the board. Her antibody RH serum is going to bind with her RH antigen. So we're going to have a 4+ there. So in that case, this makes up AB positive. Now, the interesting thing about AB positive folks is that it's the opposite of O folks. They don't have any antibodies. They have the A antigen and they have the B antigen. So they're not going to have A antibody and they're not going to have B antibody. So that's the big chart I wanted to go through. We started off with some pretty elevated material in Bio139. It's not all going to be like this. So if this is something that you think is completely foreign to you and, you know, this is wigging you out, this will probably be one of the more complicated topics we'll go over for the entire semester. It'll probably make up anywhere from 1 to 5 questions on your exam, probably out of 100, maybe 90, because we do cover so much because this is an introductory class. I don't want this to keep you up at night. There'll be more concepts for the taking. Okay, so just keep that in mind. It will be on the first quiz and all that, but it won't make up the entire class. We just started off heavy. Okay, now this is where we get into flashcards, and I'm not going to talk too much about this. Because this is just spending time learning arteries of the pig and the different vessels and circulations of the body. You all should all have that in your lab, okay? There's nothing for me to add there that would be enticing. I don't have any cool stories. This is like the part where it's since it's an introductory class, you have this memorization aspect, and this is kind of what we're getting into. So I recommend you all try to do the flashcards. Now, when I'm going to go back there, if there's answers for the lab exam, I will take pictures of it. This is what I did last semester because everybody did this from home eventually. I maybe had like 1 or 2 people show up ever so often, and everybody did Zooms. I will take pictures before I leave tonight. There are some of the answers are in the back, and then I will email that out to everybody unless you guys in person want to go back there and snap some pictures, because I don't think the answers are in your lab manual. Some of them are, some of them aren't. So for you online people, you'll get something from me in the middle of the night. Well, let's see. Page 9 is a labeling exercise. You can kind of see where they want you to label all these, and you can do this tonight, or I can send you the answers and you can do it on your own time. It does say use your textbook and the lab website to label all the veins on page 10. It may be. I think that's something that they might have tweaked this semester, where they added, because most classes are online, I think they might have added, there is a lab website that, yes, there's arteries. Okay, you do have the label. Okay, there's some of them you may not, but let's just see. Maybe I'm wrong. No, 9 is blank. 9, go to 10. What's your answers on? Is it page 11 or 12 or 12? Okay, so 12. Yeah, 9 and 12 go together. This will be something we just may have to work out a little bit. Like the neck, I don't think the neck has any of the answers. The neck is on page 14. I'm going to have to get you the neck. That's all right. I may take a picture, or you all can with you may have updated phones compared to me if you're into that. Let's take a look back here. Okay. So we got heart, we got Okay. So here's our neck. Here's our neck answers right here, guys. Here is, I believe, the veins, and here are the arteries. I do recommend taking pictures of these and studying them if they're not in your lab manual. Okay. You online folk, I'll take care of you guys. Okay. 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 So now let's jump on down to this case study on page 15. And I'm going to get a little ahead because this is more fun to talk about than doing memorization. A 23-year-old BCTC student was in one car accident and was badly cut on the arms and neck. A passing state trooper stopped to investigate the accident and pulled the victim from his overturned car. He noted a pulsatile bleeding from the wound on the victim's left arm and a steady flow of blood from the wound in the neck. All right, so let's just stop right there and digest this. So we have a pulsatile type of bleeding. We have more like a oozing type of blood. What's up? Yeah, see if they work. Does that tell you all anything? The pulsatile part? Yeah, like you're pulsing, like your blood's gushing out, like pulsing. So what is it? What does that tell you all? What could be causing that pulsatile? Well, the other thing that pulses in our body is the heart. Boom, 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 boom. So if you have a pulsatile bleeding wound, chances are you've struck an artery. That makes sense? That's how your circulation travels in your arteries. Is it kind of goes? It's well, I can't think of the word. I guess it's a pulsatile circulation. Your veins, on the other hand, go back to the heart, and that's more of an oozing. So when you have, like, normally if you were to cut yourself with a knife, cooking, etc., whatever, 9 out of 10 times you're gonna you're gonna be bleeding like an oozing situation where you've struck some capillaries, or maybe if you've bled a little bit more, you might have hit a vein, and that's just plug it up and move on. An artery is a lot different. Artery's a lot different. That's how you bleed out if you're not careful. Okay, so of the major bleeding sites, which one is more serious? I'll let you all answer that, huh? The neck, yeah. All right. So which one was the neck? The neck was pulsatile, right? That's an arterial bleed. So that's more important. You bleed out a lot quicker on an arterial bleed than you would a vein. We okay online there? Let me check this chat. Yeah, you're right, Andrea. She said it's by the artery. I'm like, yep. That's exactly right. Okay, the damaged vessel on the left arm. Is the left arm the oozing one? Right? Huh? Yeah, okay, so that's vein. That's a venous wound. And then we already answered the one on the neck, right? That's an arterial bleed.
Wait, it says that the neck is the steady flow.
Oh, it does? Okay, I'm sorry. Well, in that case, the steady flow on the neck is the vein. Sorry, I got them confused. Sorry, guys. If you have a steady flow, that's vein. If you have a pulsatile bleed, and you've probably seen this on movies or something like that, where blood squirts into the air, that's basically the pressure of the heart. You have your blood pressure of 120. That means that blood is shooting through your arteries at 120 millimeters per mercury, likely probably around 90 because it's not close to the heart. But still, when you have this rocketed blood, that is an arterial bleed. Sorry, thank you, Brittany. Okay, so in the patient's vascular system, where would the velocity of blood flow be the slowest or the fastest? Well, The slowest would be the veins. And then the fastest would be the arteries. That's where we kind of get into physics, right? I want to see if we want to go into something else here. Capillaries. What do we know about capillaries? Capillaries are a part of the circulation that will exchange oxygen through the smallest of tissues. Your fingers and your toenails still have waste that needs to, waste is what I mean is CO2 that need to be removed and exhaled out. Capillaries is the smallest vessel that reaches the tips of your fingers, reaches your gums, your ears, everything, because that's tissue too, right? That has to get carbon dioxide moved out, metabolic waste moved out, and either into your kidneys, your stool, or your carbon dioxide out of your lungs. Because, and capillaries are also the site where we have what you said, diffusion, right? Where you have oxygen coming in and oxygen coming out. So capillaries, the interesting thing about capillaries, yes, veins are the slowest and arteries are the fastest, but the true answer to the slowest blood flow in your body is the capillaries. Because capillaries, this is just a physics thing. Arteries are big, right? They're big. So we got a lot of different motion going in here. And things are moving fast. Veins are a lot smaller. Veins may be like this, so things run slower. Capillaries are very, very small. And what happens is that you may have like, let's say you have like what's called an arteriole right here. And then eventually things branch out. These are like my little vessels. So all of a sudden you get all this blood going in different directions. And that slows the blood down enough to allow oxygen to come in and carbon dioxide to go out. There's no way in hell you can get oxygen and carbon dioxide to diffuse in and out of red blood cell when it's running this fast in your neck or wherever. It's just there to get it to the destination. When it reaches the destination, this is your destination. When things slow down, and then oxygen is able to come in and carbon dioxide is ready to come out. So that's something that's more elevated. That's something you won't have to know. Guys, I want to show you this real quick. This is your artery right here when things are moving very fast, right? You're not going to get any diffusion through here. This is like your vein. Things are a little bit more slower, okay? Now, when we get into capillaries, things begin to space out. It's called surface area. And what that is that this is my vessel, and this is like my different vessels going, like spreading out. And this is like what you would see in your fingers and your toes and stuff like that. And as things slow down, that allows the diffusion of oxygen and carbon dioxide. You will never get any, well, you'll get some, but you won't get a lot of diffusion through an artery or a vein. Blood is just moving way too fast. So eventually you'll get into your higher level nursing or hygiene or surgical tech, all the other different fields. And you may cover that in more in depth. In what part of the vascular system is most of the blood located? That's a tricky one. What do we know? What do we think? That question's opened up to you guys too. In what part of the vascular system is most of the blood located? So we have capillaries, we have veins, we have our arteries. I think that's it. Or is there a guess? Throw me something. It's actually veins. It's veins. Veins can swell, I think. Well, arteries swell. Arteries can expand and swell. But the majority, I guess I should just keep this simple. The majority of your circulation lives in your veins. Okay. Yeah. So if you're in phlebotomy, phlebotomy will look for veins. I was never good at phlebotomy. You didn't want me coming at you with a needle. I'd probably be better if I gave it more practice, but I just didn't. From the place where I work, we have phlebotomists, and they're very good at what they do. Yes, so if you're into phlebotomy, they're not going to stick you in the artery. They're going to come after you. They're going to come after your veins.
So I have a question.
Yes, ma'am.
So the blood being pumped from the whole body to the heart is more than the blood being pumped out.
Correct. Yeah. The most reserve of your circulation is found in your veins. Now, I think I know the answer, but I'm not confident enough to put it on recording and give it to you all. I think there's just enough arteries as there are veins, but veins can pool blood. What I mean by pool blood, they can hold blood. They have these valves that are one-way valves. And somehow what happens is they permit backflow down because they send blood to your heart, but they prevent backflow because they have these veins, they have these valves that come down. I'm not sure if that's why, but I've always known that there is a majority of your circulation is found in veins versus arteries. Maybe because veins are a lot slower. Think about that. Think about it as from a velocity standpoint, a speed standpoint. When you have arteries coming, arteries are can be stringent, and they will blood. I mean, for lack of a better term, blood just speeds into the arteries. Like it goes to where it needs to, where this artery is taking them. If it's the brachial artery, it's down here. If it's the renal artery, it's to your kidneys. Okay, and the purpose of arterial blood is to deliver oxygen to the needed organs. If anybody's gone on a treadmill or done any kind of exercise, your legs get tight because it's sucking up a lot of oxygen and it's producing a lot of metabolic waste. And the purpose of the arteries is to get that oxygen there as quick as possible. Veins, on the other hand, are just there to recycle waste out, and then eventually they will enter back into the arteries and they go into the heart. So we'll talk about circulation with heart after that. When we get into the cardiovascular system. Okay. So let me check the chat here. Okay. So we're good on chat. Now, all right, that brings us to lab 2, 7:50. It's a pretty good time. So we've done blood bank, we've done anatomy that you guys can do. I'm gonna get you some pictures for you to study. We will have a quiz open up, I think, this Sunday, and I may have it run through Thursday. Probably that gives everybody 5 days to get to understand it. And you'll get an email from me, and make sure, I think everybody's getting emails from me. So that's good. Sorry? It's timed. Yeah, it's timed. Yes, both of them will be timed. Well, yes, yes. Okay, I'm going to cut this. Yes, ma'am.
Is it multiple choices or
That's going to be, no, that's a good question. Now, the way Mr. Davis does his quizzes is that they're fill in the blank. Now, don't freak out. If you get something close, then I know what you're saying, then I'll give you the credit. So just put something, don't skip it. Don't skip it. Give me something. And then if it's close to the spelling, or I think I know what you're trying to say, I'll give you the credit. Okay. It's important that we do well on the quizzes, so you know what you missed and you know what you got correct, so you know what to focus on with the exams. So I think last year I even returned some of these quizzes, and I don't think anybody else does that because they make their way onto the internet. But it's important that you guys understand what you got right, what you got wrong, so you can study it. I'll give you all the material you can. I mean, you're going to have everything. You're going to have a study guide. You're going to have what you got right, what you got wrong, but you have to put the time in to figure out what's going on with it. Okay. I can give you everything. It's going to be there laid out for you. There's going to be no trick questions. It will be timed. Like I said earlier, you're going to get an adequate amount of time from me to learn the material. So you just got to sit down and spend time with the material. The thing that sucks, since this is introductory class, and I did it too, is that you have to do some flashcards. All right, you got to do some jugular, left jugular, right jugular, stuff like that. And sometimes people like that. Sometimes people like just get hammered on that quiz on the test. Those are a definition, like what is this vein? What is this cell? You know, stuff like that. We have cells laid out over here on the microscopes. The pictures on the quizzes and the exams are going to look like just the quizzes from the lab manual. All right. Last year, they put a red blood cell on there. Make sure you go on Google what a red blood cell looks like. I think we have them over here, but some people got that wrong because I don't think they have a red blood cell picture on the lab manual itself. So Google what a erythrocyte looks like. It's pretty simple. It's just a big old red circle, maybe a little white thing in the middle because that's where the oxygen goes. Looks like a donut in some cases. Yes, ma'am.
It's not about labeling just like word based on
There will be questions about function. There'll be easy, I'm going to call them easy questions because it's pretty much regurgitation of the flashcard. What is this vein? What is this cell? Now, the conceptual questions is the blood bank stuff, right? If Mr. Smith has AB positive, then what antigens does he have and what antibodies does he have? If Mr. Smith was to be transfused, what blood do we give him? Okay. If Mr. Green comes in with his O negative blood, who can receive Mr. Green's blood? Everybody, because he's universal donor. Think about that. Universal donor is the fancy way of saying his blood can go anywhere. Okay. So those are going to be the conceptual questions. And then what I'm going to call the easy questions are just fire back what this vein is, you know, tell me what this cell is. When we get closer to the exam, when the exam comes down to me is when I'll probably just kind of jot down some important things on the study guide. And then that email will come out late because the test will not be made till late. What I mean by late is 48 hours out. And by the time I get it and I look at it, you should already know, you should already have studied. And then you look at my study guide and you're like, okay, yes, I'm good on that. Yes, I'm good on this. Because the purpose of the study guide is to make sure students have the opportunity to get the high yield points. What I mean by high yield is that, yes, this information is definitely going to be on this exam. You better make damn sure that you've looked over it, or you're going to be giving up 7 or 8 points. You know what I'm saying? 10 points is letter grade, by the way. So I'm going to give everybody tools, I think, to succeed. Now we're off, your section's off to, you know, last week, I'm not sure what happened. I apologize. I think we messed up on some communication, but I think we're caught up now. We only missed the syllabus really, which is nothing, not a lot at all. But I'm gonna end this online because I think you guys have already talked about this. I'm gonna speak to my in-person people. Do you all have any questions for me on the Zoom? Okay. Well, let me know if something pops up, and I'm gonna end your all's recording.
Excuse me.
Oh yes, go ahead.
Right. Did you say you had no syllabus?
No, I do. It should be on Blackboard.
I can't access it. It doesn't give me the option to download.
It doesn't give you the option to download. Can you see it?
Yeah, I can see it, but like I can't download it.
Okay. I may send me an email, and what I'll do is I will attach the syllabus and send it to you through email.
Okay.
We'll just do that. I can't explain. That may be a computer issue, but we can get around that. It's not a big deal. And if you need the lab manual, I'll try to do that. The lab manual is a lot bigger. That may be hard.
Yeah, no, I have the manual.
Okay. Okay. Cool.
Mm.
All right.
Yeah, I just wanted the syllabus.
Okay.
That's fine.
All
Thank
right.
you.
Let me know. Let me know. I'll get it to you tonight.
Okay.
All right. So I'm gonna say goodbye to you guys, and we'll catch you. You'll catch an email from me probably this weekend, and I'll see you next week. All righty. All right.